perform our fourth surgery for today. This will be a Deuk laser disc repair on a gentleman who has basically 3 herniated discs in his lower back and back pain. How long has he had back pain?
He said for over 10 years, but it's been worse over the last 6 to 8 months.
Yep.
Understood.
I concur.
Shot. Jordan, again, you're seeing too much of the belly. Okay? You're fine. Now you need to drop the table. I need to see the back.
Coming down.
Come on. You guys got to have all this set up before I get here. Good. Shot. That's too much. Okay. All right.
Good.
Shot. All right, so now let's take a look at 5-1. It looks like it's off orbit. The first step here is going to be to get down to the disc, 3 discs in this case, that we need to treat. To do that, I'm going to be placing a needle and this will take some time. It's the other way. You see how the pelvic inlet, that's better. That's pretty good. All right, let's leave it there. Luis, you may be right. Just lay still. You're fine, Sean. You're okay. It's Dr. Deuk. Everything's all right.
Finding that bad disc for you. You're doing great, buddy.
Sean? Huh? Sean? Yeah, you're going to feel a little bit. AP? Let's see where we are. Good. You can make him a little more sleepy. All right, so he's got a little bit of scoliosis. Back to a lateral. Yeah. Let's see. Luis, we may need a longer one.
We got it here, just right now.
I think you're right. That's interesting. You're doing great. Just lay still. Shot. Try to help me out here. Shot. AP. You're okay. All right, so we're using our x-ray machine, front, back, side-to-side views.
Keep your head down.
Uh-huh. Well, we're looking like the trajectory is pretty good. You got to go back to a lateral. That's it?
Yes, sir.
Yeah, I think that's the facet. Shot. Shot. That's the iliac crest. We have to get past. Shot. Have to come from a little bit higher up. He is not going to be an easy one because he's a big guy. For our viewers, he is actually How tall is he?
6'5".
6'5". And you're off on your orbit again. Do you see that at 5'1"? Try to fix the orbit. That's better, I think. Keep going. That's a little better. You're right. I have a feeling you're right, Luis. We're going to need a little bit longer needle. We have a special needle for really tall people. There we go. That's better. Shot. At least we're heading in the right direction. Shot. And yes, it is harder to see because he is a thick patient. Thick is in muscular and big. So it definitely makes it harder. But the good news is that's much better there, by the way. The good news is that he's not going to be impossible. I think we'll still be able to get this done. So I've told you guys before, 5'1" is the hardest, right? So comes as no surprise. Shot. Shot. Interesting. Yeah, shot. He has a high iliac crest too, on top of all of that. Shot. 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 Gonna have to start a little more medial. Unfortunately, this is one of those, I keep hitting the iliac crest. We need to be a little bit more medial. Shot. Shot. I'm gonna have to start further up. How's his vitals? Let me have some more numbing medicine. I'm sorry? Yeah, but I'm going to need your help. I can't be numbing every single part of his body. So he's going to be difficult in terms of having to start and redirect in multiple layers and directions. I can't be injecting every single time. You know what I mean, Shot? You know what I mean, Joe Green? Can actually give too much local. Shot? Huh? You cannot with propofol? Huh? Oh, it does? So you're saying that propofol affects,
With emulsification, it binds the local anesthetic in the blood.
so it doesn't cause the cardiac effects? Shot? Wow. AP? Too medial. I need a little bit more lateral. Shot? 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 It's close. Shot? I'm just hitting his facet. That's the problem. Luis, I need to keep this writing north up top. Watch out. Shot? 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 Very close. Shot? Shot? Might have it. It's really hard to tell. Jordan, can you help me see that better? Don't do a pulse view. That's non-pulsed? Shot? Ugh, I need to do a better shot than that. It's a good idea, but it's a bit overexposed. You need to work on that to make it better. Can you do a little better? Is he awake? I gotta be able to see that. That's a little better. What do you think, Luis?
I think it's better now. Yeah.
It's not great, but can we do better than that? Jordan, I just need to be able to see it better. I know, but we've got to succeed. We can't just try.
You don't want to try to get a 4-5 first, and then when we open, then
Yeah.
more space there.
Well, I'm gonna do 4-5 now. While Jordan is messing around there,
You want the long one or normal?
I'll do a normal.
Okay.
Let's see what the normal does. I'm gonna make his incision a little bit bigger than normal. All right, Jordan, try again. Whew. He is big. Thick guy. It's a football player right here. Huh? Yeah. Yeah, he's big. It's okay to say he's big because he's big. You know? It's the truth. I think we're going to be struggling with the shot. Shot. The bottom one looks better though. Shot. Give me an AP. All right. You have another one of these, Luis? Yeah, I understand. All right, Jordan. He's got some scoliosis. You can see that. Huh. I think we're going to need the longer one. Shot.
Right, take Oscar, please. Thank you.
Just
Thank you.
shot. That's incredible. AP. All right. Little too medial. But I'm all the way to the hilt. Shot. 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 Yeah, it's not long enough. I feel the facet. Shot. It's almost long enough. Not quite. Shot. Let me know when he's awake. It looks like he's waking up a little bit. Shot. No. I'm going to want to see what's going on at 5-1. You're okay. Dr. Deuk here. We're just trying to get down to your bad disc. All right. Shot. Shot. How's he doing anyway? Shot. I don't mean that. Vitals. How's he doing vitals wise? Shot. Everything good? Shot. You're okay. We're just trying to get down to where we need to be. Shot. 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 That trajectory looks pretty good. Shot. Let's get an AP. I like that trajectory. You all right?
What's hurting you, my friend?
That looks pretty good. Let's go back to a lateral. Yeah, you're fine. Dr. Deuk here. This is the worst part. I get it. we're almost done. Shot. That's looking pretty good. Where do you feel that? Don't move. Shot. Yeah, let's get an AP. AP. So we're using a combination of front, back, side-to-side views to make sure that we're navigating not just to the right disc, but also through the right area. That looks really good. All right, let's go back to a lateral. So this 4-5 is not as hard to do as 5-1. 5-1 is the hardest. All right. Shot. Where do you feel it? That's definitely one of his bad discs. Yeah, we got one of your bad discs. Is he still awake enough to be reliable? Yep. I'm going to look at 5-1. Are you okay? Shot. Where do you feel that? Where do you feel that? Back or leg? Yeah. Yeah, we're off. We're good. You're okay. Let me see. Shot. Yeah. Well, we're going to need him to have a little bit more anesthesia in a second, but not right now. We're right at the facet. Shot. Shot. Well, we got the one in. Now we're trying to get the next one. Shot. I just cannot. Shot. So in any way you can get me a better picture of that? I don't need 4-5, I just need 5-1. The problem is our patient is so muscular and thick that the fluoroscope is having a hard time getting through all the tissue. Where do you feel that? Where do you feel that? Back or leg? Ask him where he feels it.
Where is it going down your leg? Where? Knee? Foot? Thigh? Tell me where it is, man. Where's it hurting you? Huh?
I can wait.
Huh?
Where do you feel it?
All the way down his leg.
All right, I need to make sure 100% where he's feeling it. So you think he could be a little more awake? All right, let's do the next one at 3-4. I'll come back to 5-1 when he's a little bit more awake. I mean, the position of the needle looks really good right there. Maybe we'll just wait here. Let's see, since we got the x-ray needle position that we want. Are you awake?
Hey, buddy, are you awake? He said yes.
I mean, that looks pretty good. Go AP.
Keep your head down.
Maybe that we're too lateral. That may be the problem. Yeah, I think we're too lateral. I think the facet is pushing me lateral. We're right on the lateral border of the facet. See that? So can I reposition it? That's the real question. Let's see that lateral again. I might be able to see that. Looks to me looks really good. How reliable is he, you think? Huh? All right. Are you having any pain?
He said not right now.
Where does he feel it?
Where's it going? Where's that? Tell me where. Hips and leg.
But how far down your leg? Where do you feel it?
Calf.
All right, yeah, we're too close to the nerve. I'm gonna have to try to come a little bit more of an angle. Shot. 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 Huh?
What'd you say? His lower back is cramping.
Yeah, yeah, we're right where your bad discs are. That's normal to cramp some cramps. We just want to avoid anything in the leg. Shot. 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 Let's see where we are. Shot. That may be the iliac crest there. Just a little bit too lateral. Actually, yeah, I'm certain it is. Just relax. You're fine. Shot. All right. Let's do 3-4. Let's try a normal one first. This is the same one we did before, right? You're okay. You're okay. Shot. Yeah. Shot. Yeah, I think we're going to be too short again. Shot. Shot. Let's try to help him a little more. You're doing okay. We're almost done. I'm right on the facet joint. Need to be a little more north. Shot. 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 Oh, we're awfully close. Shot. But I think we are going to need a longer one again. All right. Yep. So the shorter needle that we typically use just isn't reaching. So we're having to use a longer one, which is fine. That's why they're designed for. But typically 5-1 is the one that requires the longest. Shot? So, shot? 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 Shot. So I'm up against the facet again. Probably a little bit more medial than I want to be. Shot. Too high. Shot. 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 It's better. Shot. Close. Can you fix that disc space there for me? Shot. Can you get it lined up a little better, Jordan? See how we're off on wag? Just the slightest amount. You look good at the pedicle of 3, but the pedicle of 4 is off. It's worse now. So he's got scoliosis, which is what's making it harder as well. That's better. Let's try to do it with that. Shot. I feel like I'm right on the facet, which I am. I'm gonna go around it. Shot. Okay, let's get an AP and see where we are. So I think we're going to be okay at 3-4 and 4-5. 5-1 is the one that I have some concern about. Yeah, it looks good. What does he want?
He wants help. His mask is irritating.
All right, let's go back to a lateral. So it's looking good at 3-4 and 4-5.
Better? Yeah, you're doing great, man. You're doing great.
But you see how the spine is curved? It's making it very challenging in terms of getting. You okay? Where do you feel that? Shot.
Where do you feel that? Side down the leg.
How far down the leg? There's no way. AP. I think what's happening is he's tightening up. Knee?
Maybe now the knee.
Yeah, the knee. That makes sense. Not the calf. Yeah, that looks good. That looks really good. Let's keep him awake because I want to do a discogram.
Okay.
And I want to try one more time at 5-1. All right, so we're perfect at 3-4 and 4-5. The issue is, can I get L5-S1? I've already tried several times, have not been able to. I'm gonna try to maximize my picture. I mean, Jordan, you've done a pretty good job. Those pedicles of 5, though, I think they're off a little bit. I think we have to do some orbital stuff because there's some scoliosis there at 5 that is changing the alignment off compared to 3 and 4. So you're gonna have to go out of alignment at 3-4. That's not better, that's worse. Shot. That may be better. That looks better in a way to me. It looks better. And it kind of looks, I don't know, what do you think, Luis? Looks better, yeah. In a way, it does look better. All right, let's give this one more try. Now, let me think. I was struggling. I need to go further down. Yeah, this, on a scale of 1 to 10, this is a 12, folks. This is as hard as it gets for this type of procedure. So I'm not giving up. I really want to try to fix all the discs that he came here for. Shot. But at the same time, you have to recognize that, you know, once you've done all the reasonable try, if you can't get it, you're going to have to basically give up at some point. You don't want to cause any problems for the patient. Shot. Could be a little more north than that. Shot. Shot. That trajectory looks pretty darn good. But we are up against his bone. Shot. That looks like his facet, possibly. Let's go AP. Let's see where we are. It's got to be lateral. That looks lateral. So the nice thing is that we're working in a space right now with these needles that's not dangerous to the patient because it's all basically thick muscle. Yeah, we're lateral. Show me where the needle is, towards me. Bring the scope towards me. It's because of the spine. Yeah, we're lateral. That's what it is. All right, go back to a lateral view. I'm real happy with the other ones, but this one is just so difficult to do. You're okay. Shot. That's the iliac again. Shot. Shot. You're okay. Shot. Shot.
We're almost there, my friend. We're on the last one.
Shot.
Take a couple slow deep breaths.
You just get it close enough. Shot. Just a little too lateral, I think. Shot. Yeah, that's the bottom one, my friend. You're okay. We're gonna almost done. We're gonna put you to sleep soon. Let me see what we got there. Shot. I think we're off there. See the pedicles of 5 seem to be offset, not on a wag, but on a rotational thing. Can you improve that a little bit there, Jordan? My trajectory looks good, but maybe the other way, I don't know. Try some more. Shot. Try some more. Try some more. Huh? It is going back, yeah. But I think that's as accurate as it's going to get. All right. Almost there. You're doing great. Just hang in there. We don't want to stop now. We want to get this right.
Couple slow deep breaths.
Shot. All right, let me think. Shot. AP. Could try this trajectory again. Try to go a little bit more lateral. See how lateral we are already? We're right on the edge of that facet. I'll try and go a little more lateral. Shot. 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 Oh, it's so close. So damn close. See it? You see it, George? It's right on that facet joint. It's just getting caught up there. I'm so close. You know, I'm gonna go for it when he's asleep. Let's just get started. All right, keep him awake right now for now. Are you comfy? Are you comfy? Is he awake? All right. So, let me think. Yeah. Get him comfortable. All right, we're going to put you to sleep in a few minutes, okay? Can you hear me? So our patient has he's very muscular, has a big back. Anyway, he's got 3 discs that are herniated on the MRI, L3-L5 and L5-S1. And each one of them has a tear, and that's where the pain's coming from. Are you comfortable? Is he reliable yet?
Yes. How you doing, my friend? You all right?
Yep. How bad is that on a scale of 1 to 10? How high?
0 to 10.
I think he said 10.
10.
10. Is that where you get your back pain typically? Here. All right. That's a 10 out of 10. It's okay. We're done. I apologize. So we just tested that disc, and the L3-4 is a 10 out of 10, and it's where he typically gets his pain. You could see the tear on the discogram. So he's got a grade 5 tear there. Are you better? No, you can't get up for a second. How bad is that on a scale of 1 to 10? How high did it go? 20. All right, is that where you get pain typically? That's L4-5, 20 over 10, concordant. All right, we can put him to sleep. So I wanted to test the discs that we were in, and testing them shows that indeed they're causing his pain. Hey, when you wake up, we'll be done, okay? You did great. I'm sorry it was so painful and uncomfortable for you, but you're going to go to sleep now. You're going to feel a whole lot better, I think, when you wake up. That pain will be gone. I couldn't understand him.
What do you say, my friend? He's very uncomfortable.
Yeah, just go with his neck.
No, with his waist and his chest. Both are very uncomfortable.
All right. Shot. So we've tested these discs, and now we're going to, you know what needs to be done, huh? You remember this, right?
Yeah.
Uh-huh.
Got it?
You have something pointy that will go in there besides this? Shot? Shot? Huh?
No, that's skinny no. I mean, the stylus from that, if you want to try that. You want to push more or something like that, or?
Shot? Which one is this?
There you go.
Which one is this?
Which one is what?
Disc.
The disc, this is 1.5.
There we go. All right, that worked. Nice job, Luis. Nothing easy about this surgery, folks. This is going to be very challenging. Just because his spine is so far forward in his back, and you never know how far forward a spine is going to be until you actually get in there and do this. So, unfortunately, his spine is extremely anterior. Shot? Well, we are going to maximize our instruments. These instruments are made for normal people, and there is some ability to accommodate a bigger person. Shot? Hold on, not yet. Not yet, not yet. You're okay, you're doing great, just breathe.
Slow deep breath.
So he's going to sleep right now? And he's tightening up and I can feel him. He's not letting this go in, the dilator. Let me know when he's more comfortable. I'm just testing to see. Wow. Wait, let's see. Sure.
Yeah?
Yeah. Shot. Lay still. You're okay. You're okay. Yeah, there's not much. Let's just wait. Just wait. That L5-S1.
You can see it.
Yeah. You're okay. Lay still, Shot. What is it, Luis? I am going to need to use the just extractor. I think we're okay. Let's pull this back a little bit. Let me have it. Yeah, I mean, it's honestly, we've taken it to the limit of what this thing can do.
Do you want to put
I can put a
sucker
little bit
first?
further.
No. Fun.
Yeah, I understand what you're saying. Yes, I agree with you. The fluid
Because,
shot.
oh my goodness.
No, we're okay. We're okay. We're okay. You can put the fluid adapter over it. Yeah, go ahead. It'll snap on. Right? That's how it's designed. Take that. All right, we good with the fluid? Let me see it. We good there? Yeah, like I said, we've taken everything to the maximum. Shot? That looks good. Looks good. Huh? Mm-hmm. Yeah. If he was any bigger than he is, we wouldn't be able to do the surgery. Shot? Hey, I don't select who's going to be a patient. God selects them. I just do my best for them. Woo! All right. So, folks, we saved the hardest for the last. No doubt about that. He's sleeping. He's happily sleeping right now, very comfortable. So don't worry about him. You're going to do my wrist? At this point, we're going to bring the endoscope in and we're going to repair this disc. We're going to be able to repair 2 of them. I can't get the L5-S1. It's just not possible because of his anatomy. His spine is too anterior, his facet is too large, his iliac crest is too tall. Any questions from our audience?
Not a question, but this person from YouTube named Teak has said, well, maybe a question. Always wondered if ketamine could be used in conjunction with propofol for cases like this.
Yeah, we use ketamine. Dr. Berndes is the anesthesiologist. He has ketamine. And Dr. Berndes, how do you feel about ketamine on a patient like this? From one of our viewers asking. And so just simply put, you would not use it because of his airway. And specifically, he's worried about, what are you worried about? Multiple drugs that we're using, having an effect on each other and causing him to not be able to breathe properly. So, safety, patient safety. We wouldn't be able to do it on this.
Type of case, a more complex case, you keep it as simple as possible.
Dr. Berndes says, keep it simple on a complicated case. Otherwise, we have used.
25 years.
Yeah, nobody's challenging you, but I think they just want to know why or why not, and we use ketamine from time to time.
I'm a big believer in ketamine. I like it.
Yeah, Dr. Berndes says he's a big believer in ketamine for anesthesia, but not on this case because the airway is too difficult to manage.
And also the blood pressure.
So you can see the disc is pretty badly damaged before we got here. All of this fragments of herniation are evidence of a traumatic injury to his back at some point. All right, there's a big tear there. Wow. Yeah. We have not had to use the long needles in years. I don't know, have you ever used them with me?
Yeah.
Once?
A couple times, but just like you said, years.
It's been many years. So it's very rare to have a patient this large, I mean, with this deep of a back. He's not fat by any means, he's just thick, like muscular. I was joking with him in pre-op and I said, you've got to have some Norwegian, some Viking blood in you, because you look like you're built like a Viking. Oh. We're not going to be able to do L5-S1, so you can make a note of that due to anatomical constraints. Yeah, unfortunately. Everything okay, guys?
Yep.
Well, you know, we would never be able to get this tube at 5'1". No, stop pulling that against my finger. All right, why don't you run the video, Henry, showing our audience how does a tear in the disc cause so much pain for patients? Can you do that?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. Everything is going well. We were not able to get into the bottom disc because of the patient's anatomy, but the other two discs we were testing and definitely are causing his pain. So he's going to get great relief from these two. This is the L3-4, L4-5. He's got herniations. You can see them coming out. But he's doing well. Dr. Berndes is doing an amazing job with the anesthesia. Patient is stable. This is the most painful area. Look at that inflammatory tissue right there. That is the part of his disc that's causing him the most pain. So we're able to get it and treat it, which is real good. This would be impossible to do without the laser. So it just highlights how important the laser is in this procedure.
We have another question.
Sure.
It's from Teak once more on YouTube. And they asked, what would be his next option for L5-S1?
Yeah, so he's going to have to see how much pain he has at L5-S1. And if it's bothering him enough, then the next option would be a fusion, in my opinion, at L5-S1. Because we have all the equipment available, the best machines, the best tools, the best everything, and if we're not able to get it, which we're not, I tried and tried and tried, then there's nobody else that's going to be able to get it. Most spine surgeons that do endoscopic, and there's not many, they won't even do surgery at L5-S1 because it's so hard to get to normally in a normal person. He's not normal. He's a big guy. He's very, very big. And, you know, it's not just his size that's the issue. It's the facet joints are so wide and the spine is so anterior, meaning it's so far forward in his belly and his, you know, in his abdomen. So it's just not possible. No, there's nothing I can do, nothing anyone can do that's going to get it. So the only other thing to do would be to do fusion at 5-1. He could do an artificial disc at 5-1. I wouldn't recommend it. But that is another option. He's going to have really good relief of his pain higher up at the 4-5 and 3-4. He's just still going to have the bottom of the spine pain at 5-1. So how much pain will be left, I don't know. It's impossible to say. I've been surprised sometimes. I can't get the bottom disc, and patients For some reason, that's the disc that wasn't the one causing much pain. So they can actually live with it and deal with it. Now, my goal is always to get rid of all the pain, but some people are happy getting rid of 70, 80, 90%. And that means the world to them. So we'll just have to see how he's doing when he recovers. Everything okay, Jordan?
Yes, sir. He's helping me with his arm.
But definitely, this is 4-5. This was the one that was a 20 out of 10 when he told us. So this is a very bad disc for him. And this pain will be gone. And he's going to have great relief here. So will it be enough to keep him happy, satisfied, normal? I don't know. It's impossible for me to know. I've been doing this for many, many years, and every once in a while I get a patient that I just cannot get to one of their discs. And honestly, I found that out of probably all the patients I've not been able to get, there's probably 15 of them out there, maybe 1%. They seem to do well. There was only one person who had pain at that disc that I didn't get to, and he said he was a lot better, 80%, and that he was very happy and he didn't want to have a fusion. So he chose to live with the residual pain, and that's a personal choice. Yeah. It's up to him. He'll decide once he sees what's left. All right. So just about done here with this disc, and then we're going to go and do the next one, the L3-4. A lot of herniated material. You see the blue stuff? That's all the degenerated nucleus pulposus, the herniation. Grab her. Nice job, Oscar.
Thank you, sir.
Starting to get it. You know what I mean? It's an art.
I've been studying that.
Good. It's hard to be a good assistant to a surgeon, especially a surgeon who moves relatively quickly and is pretty demanding. So great question from the audience. Anybody else have a question?
Yes, we have a question from Brian Johnson on YouTube.
Brian Johnson, never heard of Brian Johnson. Just kidding, Brian. Welcome back to the stream.
And he asked, does Dr. Mork do the same thing you do?
Does Dr. Mork do what I do? Absolutely not. Dr. Mork doesn't do the same thing I do. Nope. Dr. Mork does endoscopic surgery, but he doesn't do the Deuk laser disc repair. He's not allowed to. I haven't trained him to. Dr. Tony Mork. I've met Tony Mork years and years ago. We went to some of the same meetings. He sat in on some of my talks. Last time I heard, he was out in California. He's moved around a bit. All right, so you can see how inflamed the disc is. It's got some capillary bleeding there from all the chronic inflammation. I just want to finish this up and we'll be done here. But this disc was nice. It went well despite the challenges that we've had here. It's not an easy one to fix by any means. How is he doing? Yeah, good. All right. So I'm going to come out. I'm going to do a little antiseptic in a minute. Yeah, sure. You know it's not going to make a difference. It's not going to make a difference. No, it didn't. Did you see how many times I had to redirect? You want to put more local in the disc itself?
No. Local in the subcutaneous when you're hammering. You put in the shield.
But that doesn't bother them. It's the up against the disc that bothers them. I'll tell you what, we can put a little bit in the disc, maybe. Luis, you have something to put in the disc? All right, I'm just cleaning this last bit up.
Or you can inject all the way down the needle too with your point.
That's what we're doing, yeah. We're going to put some in the disc. Just for you. All right, that's enough. Let's try one more grabby, and then we'll be done. Huh? That's it. We're done here. Tough one. Tough one. Yeah, this it's a very deep spine, deep disc. But it looks good. We got everything out. It's also got some short pedicles. You can see the facet there. All right, we're done here. This was the 20 out of 10 pain, right, Luis? Yeah. All right. Uh-huh. I'm sorry, what? Which one? The last one I just saw? I'm going to be... How's she doing? She's happy? Yeah, you can send her. As long as she's stable and doing good.
She did really well, thank you.
Yeah, you can send her. Yeah, make sure she has my cell phone number and calls me if she has any issues. All right, folks. Take that. We are just putting some antiseptic in the disc, cleaning it out. Huh? And we're going to be coming out. Now we've got one more disc we're going to treat here. Take that, take that. Not yet, I want to put pressure.
Jordan, you can, Oscar, move south. Please, huh? Move south.
What percentage is it?
It's, what percent is the margin?
This is half percent.
5%.
Can you put it on there? It's not turning on. No, it's not turning on. All right, any more questions?
Yes. The first one comes from Teak on YouTube once more. It's not a question, but it's a compliment. At least a fusion from Dr. Deuk is better than anything from other surgeons. Your team is fun to watch.
Hey, thank you. I appreciate that, but I'm hoping he doesn't need a fusion. Just lay still. He's going to get some great relief of pain. I just don't know if it's enough for him. But, you know, if he does need a fusion, it's going to be it's not going to be an easy one, I'll be honest, because he's got a very deep spine. It's no matter whether he has open surgery or he has endoscopic surgery, the fact that his spine is so far away from his back, from the skin back here, it really, really, really creates a big challenge for no matter what surgery we do, because it's gonna really stress out the instruments, and everything that's made for spine surgery is made for normal sized people. All right, you got to get, let's center that up, please. And normal sized people aren't, you know, 6 foot, over 6'5", you know, they're normal size. And so no matter what surgery is done, patients who are really, really big, I got to be able to see the front of the spine, Jordan. You got to open that up a little more, please. Shot. All right. I needed to see my guide wire. I could see it now. Perfect. And we put a little more numbing medicine. I got it. Put a little more numbing medicine in there. Take that. How's he doing? Huh? All right. So he's doing okay. He's stable. But like I said, patients like this, they stress not just the surgeon and the instruments to the limit, because the instruments and stuff are built for a certain size person, but they also challenge the anesthesiologist. Very hard to ventilate and a patient who as big as this. All right, so we still have, this incision's probably about 1 centimeter. Had to make it a little bigger because I had to fit the fluid adapter. Otherwise, I wouldn't be able to do the surgery. Shot? Do you need any stimulation? No. Shot? Is that it there? Yes, sir. All right, I'm going to pull the guide wire back just a little bit. Okay. Shot? That looks good. Remember, the guide wire is guiding this dilator into the disc, so we're actually should be safe. Shot? As long as we follow the guide wire. Wait. I want to bring the guide wire back just a little bit. Shot? Shot? All right, so wait, let me look. I want to feel it. That feels good. I got to say, in all the years I've done this surgery, he's going to rank up probably number 1 or 2 in terms of maximizing like the limit of what we could do. He's right on the cusp, and thank God we're able to do 2 of these discs, because honestly, if he was much bigger, we wouldn't be able to do any of them.
We have a couple of questions.
Yeah, just give me a second.
No worries.
Shot. All right, so we're just, you can see on the X-ray lateral view, we're just about to enter the back of the disc with the tube. And now it's going in. Shot. It's just nicely going in. Pull that back a little bit, the dilator. Just a little bit.
Jordan, take a picture.
Stop. Shot. That's better. Yeah, we're almost there, almost there. Just give me a second and I'll answer the questions. I just want to get this in the final position. Shot. All right, go ahead and take it out. And I think we got enough space for the fluid adapter, right?
Yeah.
Shot. Uh-huh. Yep, as soon as you feel, don't take the tube out though. All right, wait a second. Shot. Come on, Jordan, take a shot, please. All right, let's just wait a second. Let's put the fluid adapter on. Can you see where it is?
Yeah.
Good.
Right there.
All right. All right. Go ahead. Okay, let me see this. Let me have a ray tech. Wet. Put it over. Let's go. Wet, wet. Wet means wet, not dry. You can see that we're in the disc with the tube, and we're ready to go. Let's get the fluoro out, please. Okay, we'll take the questions from the audience.
All right. First question comes from Jacob on YouTube.
Hello, Jacob.
And they asked, how common is it after a lumbar fusion the screw breaks a year after the surgery?
How common is it after lumbar fusion a screw breaks? It's not common. It shouldn't really happen, but it does happen. It does happen, but it's rare. But again, there's a piece of herniation right there. That's good. Look, I'm gonna be honest with you. A screw breakage, there's surgeon reasons, and there's manufacturer reasons, and there's patient reasons, okay, that screws break. So the surgeon reasons are they put too skinny of a screw, they put too short of a screw, they didn't give any inner body cage or support, which is very important. You want a load sharing construct, you want an inner body cage, and then there's patient reasons the screws break. That's use of nicotine, like smoking, vaping. There's poor bone quality, like osteoporosis, osteopenia. And then there's behavioral things like doing too much, you know, going out and playing football, rugby, you know, jiu-jitsu, whatever. Getting too active too soon, and then breaking those screws. Having an accident, car accident, slip and fall, whatever. The point, what? 10 minutes. The point is there's things the patient can do to break the screw. And then there's manufacturer defects. Let's say the screw is not, you know, has a defect in it. It's not manufactured properly. There's some problem with the alloy, and you know, it's on a bad batch of metal. These screws are all metal. They're usually not stainless steel. They're usually an alloy made of like chromium, molybdenum, and aluminum. Very common. Chromium, molybdenum, aluminum, like a titanium alloy. But you know, there can be problems with the manufacturing of the screw. So it really depends the cause of the screw breakage. I've seen a lot of times it's the surgeon and a lot of times it's the patient, but rarely is there a manufacturing problem with the screw. If you go with a reputable company that manufactures implants, all FDA approved, it's very unusual for that to happen. So if you want to know who manufactures the screw, go to your operative report from the hospital, and the surgeon will tell you who the screw manufacturer is in the operative report. They're supposed to put that. I use Alphatec. I don't like the company much in terms of the people, but I like the products. And the product is very good. The screws don't break. I was using another company called Nuvasive for many years when I was starting out in my career, and their screws were breaking all the time, backing out. I stopped using them. And I changed to Alphatec, and I've been very happy since then. I haven't had any broken screws to my knowledge. So Now, you also have to put, if you're doing a lumbar fusion and you're doing an interbody cage, you want, hey, why is the scope dark? You want to make sure the interbody cage is big enough, okay? And what I mean by that is you want to make sure the cage is tall enough. A short cage will not share the load of the weight of the body. I need the, yeah, thanks. In other words, a short cage will not hold up the bones apart when you stand up and carry things, you being the patient. And so the weight of the bones collapsing will be on the screws. And all that force will go to the screws and it can shear them right in half. Okay? Remember, screws, along with other spinal implants, they're not designed to last forever. They are tested to usually 1 million cycles. So they're tested in a lab on a cadaver bone where they are loaded and unloaded 1 million times. It's called a cycle. And if they do that and they don't fail, then usually they can pass FDA and be approved for use in a human being, okay? That's why there's so many screw manufacturers out there, is because all these companies want to make a lot of money selling these screws. But if the surgeon doesn't put the right thickness screw, if the surgeon doesn't put the right length, if the surgeon doesn't put a cage that's tall and snug against the end plates, a cage that won't crush or crumble, then your screws are going to have potentially fracture risk. So that's what I would say. Of course, that's the United States. We have a lot of viewers from other countries, and where do they get their screws? I don't know. You know? I can't even imagine. I've heard stories from neurosurgeons, orthopedic surgeons in other countries where patients have to go out and buy their own screws and stuff and bring it to the hospital for their surgery. That's a big tear right there, by the way, a big herniation that we're dealing with right here.
We have a couple more questions.
Sure.
These next two come from Brian Johnson on YouTube.
By the way, let me just say, everything's going very well for these two discs. The blue stuff right there is herniated disc, and the white stuff is the annulus fibrosus. And you can see how it's torn, and the blue stuff is squeezed through the tear. And I've been cleaning out that tear now for a while. The red is blood, and the reason why we're getting a little blood is because this tear is up against the end plate, and the end plate has a lot of inflammatory tissues which are full of blood vessels. So it's not a by the way, it's not a lot of bleeding. When I say a lot of bleeding, I mean like 30 drops instead of 5 drops that we normally get. So 30 drops of blood is still nothing. So I don't mean, when I say a lot, I mean it's relative to what I normally would get. But sorry, go ahead with the question.
The first question from Brian was, why didn't Dr. Vaccaro send me to you if he knew you?
Why would he send you? So all right, the question is, why didn't Dr. Vaccaro, Alex Vaccaro, send a patient to me if he knew me? Great question. So Dr. Alex Vaccaro is a spine surgeon. I think he's at the Rothman Institute still. I haven't talked to him in years. But the question is somebody saying, why didn't Vaccaro send me to you, Dr. Deuk? And Dr. Vaccaro doesn't do this type of surgery. He may not even know it exists, but I think he probably does. Because I think listen, if I say something, I'm going to say something, but I'm not going to direct it at Alex Vaccaro, okay? I'm going to tell you something. The spine surgeons that are in high positions at universities control about $20 million worth of spinal implants a year, maybe $30 million worth of spine implants a year. They have special deals many times with the companies that sell the screws and rods and cages. They have deals to develop, to advise, to mentor, to train and teach. And they can make upwards of maybe even $10–20 million a year in these consulting fees, okay, working for the implant companies. I know Dr. Vaccaro has those kind of relationships, for sure, okay? And, you know, he has to disclose it by law every time he goes and gives a speech. He has to disclose his financial disclosures. I have zero. I don't have any. I've never taken money from the companies, and I just never thought it was right, because they're kind of like they're buying your soul. When they take you out to dinner, when they give you money and they make you a consultant. I had one product in spine that I was involved in developing. It was a posterior cervical screws and rods, a wonderful system, and I was involved in developing it. So I sold my ownership of that, and I got out. So I was never part of that group of surgeons getting kickbacks, basically. Okay? But a lot of these busy spine surgeons at universities that are in control of training residents, they think about it. If you're in charge of the spine program and you have 5 residents, you know, or 3 residents to 5 residents a year, spine surgery residents, orthopedic and neurosurgery, coming through your program, and the average program length is 7 years, you have about 20 to 30 or 40 residents. These are spine surgeons of the future that are training right now at different years, and they're going to go out and they're going to do spine surgery. How's he doing? I'm almost done. You can let him lighten up, okay? Dr. Berndes? So think about that, the power of that. If you make if you're Medtronic and you make screws and cages, and you want all the future spine surgeons to use your screws and cages, then you hire the head of spine surgery at a university, and you make that head of spine surgery your puppet, basically, and they will use only Medtronic products at the university. So the residents get trained on Medtronic screws, cages, artificial discs, and then when the residents leave, they actually have somebody that follows them to where they practice. They did that to me too, in hopes to keep my business going. And I made, you know, when I was doing fusions, I made millions of dollars a year for these companies as a fusion doctor before I learned endoscopic. And they were, you know, their rep would come and, you know, he would buy me a coffee and he would make sure life was good and, hey, you know, what's going on? Oh, I'm moving into my new house. Oh, do you want me to come help you? I mean, they're salespeople, you know, and they keep the sales going long after the doctor leaves the training. So if you're in charge of picking the implant company for a university that's training, you know, at any time 30 residents in spine surgery that are all graduating eventually and going out into practice and going to do spine surgery, you are a very, very important commodity for these companies. And so they, Alex Vaccaro would never send patients to endoscopic surgery that doesn't involve, you know, implants, because I'm sure he's very involved with these companies. And I don't want to say anything it's not true. I don't want to say anything inappropriate. I don't know the exact relationships, okay? But I know for sure that there's a lot of spine surgeons at the universities that are getting these special arrangements. How are we doing, Berndes?
Are we done?
I didn't ask you if we're done. I said, how is he doing? Yeah, you can see we're almost done, right? Yeah, but we're right at the end here. You see this? Right at the end. So you can do what you need to do, but I'm almost done. He's not moving at all. So I think he's comfortable. I think you've done a great job. Sorry, I can't give you a better answer than that, but if you understood how it works, the system works, you would understand what I'm saying. And I'm not going to throw anybody under the bus, but I can tell you for sure that, you know, Alex is very involved with these companies that manufacture and promote spine implants, like fusion implants. So you can figure the rest out for yourself. But look up Alex Vaccaro's disclosure, financial disclosure. Look it up, Google it, see if you can find a financial disclosure. And then you'll understand what I'm talking about. They won't tell you how much money they get, but they have to say where they get their money from. So don't expect surgeons like that to send you to endoscopic surgery that doesn't use implants. It's people like Alex Vaccaro that honestly have kept these advanced techniques out of the spotlight because they don't want non-fusion surgery getting popular. All right, we're almost done. Yeah, I'm amazed here at how much damage there is here. You can see all the white stuff and blue stuff. It's all scar tissue from chronic inflammation. So this disc has been, you know, damaged for some time, but we're almost done. I'm just trying to finish up here, and I don't want to leave until it's done. So we're just going to finish. A lot of scar tissue, all that yellow stuff right there that I'm working on is scar tissue. The blue stuff down here is residual herniation that's left. Not much left. Little bone spur there. Any other questions?
Yes, the next one comes from Brian Johnson.
Why don't we wait on the questions since I'm done, and I will come there and answer them personally. If you guys can just give me a few minutes, I'm going to finish up and get out of the operating room, and I'll come answer your questions face to face. All right? But we're pretty much done here. I don't see anything left. Let me see. Yeah, it looks good. Looks really good. He seems to be snoring comfortably. You okay with him? Yeah. All right. Yeah. Looks good.
Okay, buddy. You're
Yeah,
doing great.
yeah, we're done. We're done. We're done.
Lights off.
Here we go. Well, let me see that one more time. You're okay. We're just done. We're finishing up. Give me a second and then we'll be done. You did great, by the way. Really good. All right, here we go.
Lights off. Every light. Drop off, please. Thank you. Thank you, Sarah.
Little antiseptic.
We're all done.
We're all done. You're doing great. You're waking up.
Moving your hand. Your IV's in your hand. Stop moving. Stop moving your hand. Don't move your hand. Don't move your hand. Don't move your hand. Good. Perfect.
All right. Why don't we show our audience the difference between Deuk laser disc repair and fusion? Henry?
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Crosslinks are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions,
Hi, Dr. Deuk Machen here. We're just finishing up a Deuk laser disc repair on a patient who has presented us with some challenging anatomy. And we were supposed to fix 3 discs, we only fixed 2. but I tried and I could not get into the last disc. That last disc being the L5-S1, and the entry point to the disc where the herniation is right here. And what you can see here is there's actually a very small window to work with right there. I don't know if you guys can see that. Yes?
Yeah, we can see.
And the problem is because the spine, here's the back, I'm coming in like this. As long as it's not too deep, I can get in there. But when the patient's spine is further forward and my entry point is the same, now I'm coming in at a trajectory that won't allow me to get in, and I'm actually hitting the bone and getting deflected to the side. That's what was happening. I tried repositioning different ways, impossible. So, you know, important as a surgeon that you know what your limits are as to what you can do. And you've got to be able to make adaptations during surgery slightly here, there, left, right, up, down, as an example, to optimize and make best the surgery for the patient. But once you've exhausted the reasonable derivations, deviations of the surgery, permutations, then you can't just say, you know what, I'm going to go for it anyway, because that's when you get into complications. If you go for it anyway, you're going to end up not in the disc. You're going to end up in the nerve root. You're going to end up in a blood vessel. You're going to end up in a bowel, and you're going to hurt the patient. So I've been very fortunate in 16 years of doing endoscopic spine surgery to have no complications from the surgery, zero. And the reason for that is because I know my limits and I know the anatomy, I know where things are, and you know, using that skinny needle, it's literally about a little more than a half a millimeter needle, probably around 0.75 millimeters. So let's just say, call it a millimeter. And that's a very thin object. So I'm able to direct it using the x-ray machine. And I was able to see pretty clearly the bone. And I knew the anatomy. I know the anatomy very well as a spine surgeon. But I just could not get past that gate into the disc at L5-S1. And again, it has everything to do with his anatomy. He had a high iliac crest, which was also blocking access. So anyway, we got the 3-4 and 4-5 done. I tested 3-4 and 4-5 herniations. They were causing 10 out of 10 and 20 out of 10 pain respectively. I didn't get to test 5-1 because I never got into the disc. And I'll be honest with you, had I even gotten into the disc with that needle, I was barely able to do L4-5 because the hilt on my tube was all the way maxed out. It was actually buried into the patient, and 5-1 is even further down. So I don't know that I could have done it at all. I may have had to make a big incision on his back and open him up and then put the tube down there. But that being said, not possible. And I've done many of these surgeries. And I know when I'm beat, let's just say, and beat by the anatomy. So it is what it is. We did our best, and we were able to fix 2 out of 3. I think he's going to be very happy with that. I don't know if how much pain he's going to have at 5-1. We're just going to have to wait and see. Okay? So let's take our questions.
All right. This question comes from Brian Johnson on YouTube.
Hi, Brian.
And he asked, how hard is it to remove the hardware in my back if that is contributing to my pain? You could have fixed me years ago, and I would have probably never had the pain I have today.
Who could have fixed him?
Just you in general, just like if I were to know, I would assume if he would know about you years ago, he would have had it fixed.
Okay,
but
yeah.
just like, yeah.
Well, I don't think you're one of my patients, but that said, so look, let me explain something to you. This show is about truth, okay? It's not about covering up and lies. It's about the truth. And the truth is that surgeons, they're not perfect, okay? We do make mistakes, and you know, sometimes we make a call to go one way and we should have gone the other way. But the truth is that it's not malpractice to make a mistake. it is malpractice to make a mistake, not recognize it, and not try to fix it. Okay? So, what I can tell you is that in 26 years of doing neurosurgery and putting in screws and rods in thousands and thousands of patients, there have been 0 patients where this hardware caused pain after surgery, for me, that I've seen in patients, okay? 0. But, that said, there are many spine surgeons telling patients that they're having pain because of the hardware, okay? Now, hardware can cause problems if the patient is allergic to metal. I've seen 1 case of metal allergy in my entire career, 1. The patient was allergic to titanium. They had an allergic reaction, we confirmed it, they were draining from their incision, we took the hardware out. But we took it out not because they had pain, because they had an allergic reaction. There's all these surgeons saying to people, oh yeah, your pain is coming from the hardware, let's go take it out. And then, oh yeah, let's fuse another level. Well, the reality is that the hardware doesn't cause pain, okay? Maybe I'll eat my words someday, but I'm 26 years in and I've not found a single patient where the hardware caused pain. Now, I've operated on a lot of people with hardware, and I've done the laser surgery above or below the hardware or both, like today, and I take the pain away. So what does that tell you? It tells you the hardware is not causing the pain. So if a surgeon tells you the hardware is causing the pain, I don't believe it. I don't believe it, not one bit. I think what's causing the pain is probably, if you ask me, I think it's the disc that's going to be above the fusion or the disc below. It's probably damaged, it's herniated, and it's got inflammation in the back of the disc causing pain, or the facet joints are causing the pain. You know, there's some other cause of pain besides the hardware. Now, I'm telling you, surgeons will tell patients the hardware is causing pain so they can get another surgery out of the patient. They can get more money, they get paid for it, it fills their operative schedule. I don't believe in doing that to people. I don't do that. It's not right, okay? But I know there are surgeons even just down the street from me that tell patients all the time, your hardware is the cause of your pain, let's go get it out, all right? And the patients get excited, they get it out, and they either don't get better, or they get better because the surgeon took the hardware out, then fused the next level up, okay? I see it all the time. My opinion is hardware doesn't cause pain. Now, broken screws, you know, and the spine wobbling around where the screws are broken because there's a failed fusion, that could cause pain. I've seen that cause pain. It doesn't always cause pain, but it really requires a good physical exam to figure it out. You're better off, honestly, if you want to know what's causing your pain, do an MRI review with me or come see me in Florida. I'll figure out what's causing your pain. But if you have hardware causing your pain, you'd be the first person I've ever seen in my career where the hardware was causing pain. Next question.
Last but not least, we got Wanda Jones from Facebook. And she asks, after the Deuk laser disc repair and the 1 year of no bending or lifting, and the 1 year of no bending or lifting, will the disc heal to be as good as it was before the annular tear ever occurred?
Hey Wanda, great question again. So Wanda's question was, Dr. Deuk, I want to understand how strong will that disc be when you're done with the Deuk laser disc repair and you've given that patient a year to heal? Is it going to be just like a brand new disc like when you were 18 before you injured it? Or is it going to be stronger? Is it going to be weaker? The answer is nobody really knows, Wanda. Nobody knows. I tell people that after we fix the disc and it completely heals, that it's going to be around 85 to 90% of a normal disc, okay? I say that because what I've been taught in medical school, and I don't have proof directly, is that when somebody has an injury to their body and it heals with scar tissue, collagen, that it goes back to 85% of the normal strength, okay? So that's why I thought 85 was a good number, but nobody's ever done a study. Nobody's ever tested it biomechanically. Yeah, I don't think it would be it wouldn't be humane, obviously, to take a person's spine and test it. But no, in all seriousness, honestly, nobody knows and there's no way to find out. I believe that once the disc heals, that it's probably going to be at least 85. I see how thick the scar tissue can be in these wounds, and it really glues everything together. I mean, it actually may be even more than 100%. If someday someone came to me and said, after the Deuk laser disc repair, a year later, it's 120% of a normal disc, that wouldn't surprise me. That really wouldn't. But I like to just err on the side of weaker. That way people's expectations are more managed, and they leave believing not that they're going to have a super disc, but that they're going to have a little bit weaker disc. But the truth is, nobody knows. Not even I know. But I'm just doing my best guess based on what I've been taught, based on what I see. I always say 85-90% of normal strength. Great question. All right, thanks for joining me. This was a tough case. It was really, really, really hard for me technically. I know it was hard for the patient. The patient was uncomfortable at times as I was navigating with those needles down. But I needed the patient awake because I need to know if I'm too close to his nerves that are coming out of those holes. Because if you get too close to the nerve, you could bang it, you could crush it, you could injure it. And there was one time when I was getting a little close and I backed off right away. And that was at L5-S1. So I kept trying and trying, and I just couldn't get a clean shot. Once we were in safely in the disc, we got the surgery done. It went smooth, it went fine. But it was a really, really tough case. On a scale of 1 to 10, it was a 10 plus. One of the more challenging ones I've ever done. So thanks for sticking with us this week. And I don't know if we have surgery next week, maybe. We'll look at our schedule and you can watch. In the meantime, if you want, go to the App Store and you can download the Deuk Spine Institute app and have it on your phone. You can actually check in on the calendar and live spine surgery. It's got some great information about all kinds of back conditions in there. And that said,